So good morning one and all. My topic is about effect of grade 4 distraction mobilization on pain and maximal mouth opening in temporomandibular joint disorder, a case study. So the study is done by myself, author and presenter Ashfak Abdul Khader as postgraduate student from Saveetha College of Physiotherapy, and my co-author is Dr. Ramana K. So coming on to the introduction, temporomandibular joint is a highly functional synovial joint and which main functions are like mastication, swallowing and speech. Together with the mandible, maxilla, muscles and neurovascular structures, TMJ forms the stomatognathing system. The disorder of this system is collectively termed as TMDs, that is temporomandibular joint disorders. And the symptoms include joint pain, restricted mouth opening and joint sounds such as clicking, grinding, etc. And one key diagnostic sign in TMD is reduced maximal mouth opening. That is, the range of mouth opening will be reduced and commonly quantified using the interincisal distance. That is the distance between the upper incisor and lower incisor teeth. The global prevalence of TMD ranges between 5 to 12%, affecting females more commonly and presenting more in younger adults. Physiotherapy plays an integral role in TMD management by focusing on pain reduction and functional restoration. Manual therapy, including joint mobilization, has proven beneficial in improving jaw range of motion, possibly due to its effects on muscle relaxation and neuromuscular re-education. The mobilization of temporomandibular joint also impacts contralateral structures due to its joints bilaterally linked mechanics. The grade for distraction mobilization is particularly suitable for restoring accessory glide in hypermobile joints and can be easily integrated with soft tissue release and home-based corrective exercises. These are some of the review of literatures and past researchers. D. Fabio Orbi et al. In 1998 conducted a descriptive study examining the role of physiotherapy in patients with temporomandibular disorders. The study emphasizes physiotherapy's effectiveness in improving health status and reducing disability associated with TMD symptoms. Through various conservative techniques, including manual therapy and exercise-based interventions, improvements were observed in both pain and function, highlighting the value of structured rehabilitation approach in TMD cases. And another scientist called Pavaria S. et al. In 2019 assessed the effectiveness of cervical stabilization exercises with visual feedback on respiratory function in patients with forward head posture. While not directly investigating TMD, the study reinforced the biomechanical relationship between the cervical posture and temporomandibular function. The findings suggest that correction of posture deviation, especially involving the cervical spine, can influence craniofacial musculature and TMJ biomechanics, which is clinically relevant in TMD management. And another person called Munho W.C. et al. In 2019 presented a critical review on functional pathologies involving the temporomandibular system and overall body posture. They emphasized inconsistencies in the literature regarding postural influences on TMD and called for more evidence-based approaches. Nonetheless, they suggested that integrated physiotherapy approaches combining postural re-education and manual therapy may be promising in managing the TMD. Background of the study. TMDs involve dysfunction of the temporomandibular joint, masticatory muscles and related structures leading to pain and joint sounds and restricted mouth opening. Conservative treatments like medication and splints are frequently used, but physiotherapy has emerged as a safe and effective alternative. Manual therapy, especially grade 4 distraction mobilization, can improve joint mechanics, reduce intra-articular pressure and enhance mobility. Soft tissue techniques such as temporalis muscle kneading help reduce muscle tension and while chin tuck exercises address postural corrections and jaw stability. Although each technique has shown individual benefits, limited evidences exist on their combined effect in TMD management. This case study aims to assess the outcome of a multimodal physiotherapy approach combining the joint mobilization, soft tissue releases, and therapeutic exercises in improving pain and mouth opening in a young female patient with TMD. Need of the study. Given the complexity of TMD and the growing interest in conservative, non-invasive treatments, it is essential to explore physiotherapy protocols that integrate joint mobilization, soft tissue release, and corrective exercises. A case-based approach allows for detailed monitoring of intervention outcomes and help generate clinically relevant insights. This study aims to fill the existing evidence gap by evaluating the effectiveness of a multimodal physiotherapy protocol in improving pain and functional mouth opening in a young adult with TMD. Research gap. While manual therapy, soft tissue techniques, and postural exercises have each been studied individually for managing the TMD, there is a lack of literature evaluating their combined effect as a multimodal intervention. Existing studies often focus on single method approaches, which may not fully address the multifactorial nature of TMD involving both articular and muscular dysfunctions. Additionally, there is a limited documentation of such interventions applied in real world clinical setting, particularly in younger population presenting with acute TMD symptoms. The aim of the study was to evaluate the effect of grade 4 distraction mobilization on pain and maximal mouth opening in a patient with temporomandibular joint disorder. Objectives: to evaluate the effectiveness of grade 4 distraction mobilization on improving maximal mouth opening in a patient with temporomandibular joint disorder, and to determine the effect of grade 4 distraction mobilization and adjunct physiotherapy techniques on reducing the pain levels using visual analog scale in a patient with temporomandibular joint disorder. So, moving on to the methodology, it is a case study which has been conducted with a duration of 8 weeks and an intervention frequency for 3 sessions per week. And case study is a 24-year-old female presented with chief complaints including difficulty in mouth opening and localized pain over the right temporomandibular joint. The symptoms had begun 3 days prior while consuming non-vegetarian food, while described as sharp and localized initially. The pain intensity was rated as 7 out of 10 on the visual analog scale at the time of initial assessment. The pain progressively intensified and began to radiate toward the right temporal region, especially while chewing. An X-ray of the TMJ showed no pathological findings. Additionally, there was no prior or ongoing musculoskeletal condition involving the cervical spine, upper limb, or craniofacial region that could be associated with her current symptoms. On observation, no visible or palpable signs of inflammation such as swelling, erythema, or warmth were noted around the TMJ. An audible clicking sound was present during mouth opening. The range of active mouth opening, measured via interincisal distance, was restricted to 24 millimeters, significantly below the normal range, which is typically 35 to 50 millimeters in females. And on palpation, grade 2 tenderness was identified in the right temporal fossa, indicating myofascial involvement. The clicking and localized pain suggested a possible internal derangement or anterior disc displacement of the TMJ without reduction. Based on these findings, a physiotherapy management was initiated, focusing on the joint mobilization, soft tissue techniques, and therapeutic exercises, aiming to restore joint mechanics, reduce pain, and improve functional mouth opening. And the intervention, grade 4 distraction mobilization, was administered over an 8-week period. The technique was performed 3 times per session, with each mobilization lasting 60 seconds and separated by 10 seconds intervals. The sessions were conducted 3 days per week. Now, the patient was positioned comfortably in an upright seated position with head supported to maintain the alignment. The therapist stood contralateral to the affected side joint. For example, standing on the patient's left side to treat the right side TMJ. With the patient's mandible supported, the therapist's left thumb was placed on the right lower molars to apply a gentle downward oscillatory force. In addition to mobilization, deep tissue kneading was applied to the temporalis muscle for 90-second duration, targeting the temporal fossa. And also, a home exercise regimen was prescribed, including chin tuck exercises performed actively 3 times daily in 2 sets of 10 repetitions. The outcome measures I have used in this study to note down the progress are maximal mouth opening and visual analog scale. So maximal mouth opening is a basic assessment method for temporomandibular joint function, involves measuring the joint's range of motion during maximum of mouth opening. The limits in the masticatory system's function are referred to as jaw functional limitations. Visual analog scale. It is a tool used to measure patients' pain intensity. It consists of a straight line, usually 10 cm long, anchored by no pain at one end and worst pain at the other end. The patient marks a point on the line that represents their pain level, which is then measured in millimeter to quantify the pain. So after 8 weeks of physiotherapy treatment, the patient showed a drastic improvement by means of the outcome tools, that is maximal mouth opening and the visual analog scale. So pre-test, before starting the intervention, the maximal mouth opening range was just only 24 millimeter, that is below the functional range. And after 8 weeks of intervention, the post-test values or 45 millimeters, so which shows a drastic improvement in the maximal mouth opening range. And visual analog scale, before starting the intervention, that is on the first week, it was 7 out of 10. And after 8 weeks of continuous intervention of grade 4 distraction mobilization, the pain level almost reduced to 1 out of 10 in visual analog scale. And both these graphs depicts the progress after 8 weeks of continuous physiotherapy intervention. Coming on to the discussion part, this study demonstrated a significant reduction in pain and increased mouth opening following the use of grade 4 distraction mobilization with soft tissue therapy and chin tuck exercises, compared to findings by Schaffer et al., who observed improved mandibular kinematics following conservative therapy. The current study supports similar outcomes, and Cook et al. Highlighted the soft tissue mobilization's role in pain relief consistent with the temporalis needing used in our protocol. Furthermore, the use of chin tuck exercises aligns with Pavaria et al., who emphasized posture correction in head and neck rehabilitation, and Hayes et al. Illustrated that manual mobilization addresses joint positional faults mirror in our patient's resolution of audible clicking and restricted range. Additionally, unlike previous studies, which either isolated manual therapy or exercises, this case integrates both achieving synergistic effect on TMJ function. The magnitude of improvement, 21 millimeter increase in interincisal distance and 6-point pain reduction, highlights the clinical value of this approach. However, due to single subject design, these study findings should be validated through controlled trials. So as a conclusion, this study concludes that grade 4 distraction mobilization, when combined with soft tissue manipulation and targeted exercises, can lead to significant reduction in pain and improvement in maximal mouth opening in patients with temporomandibular joint disorder. The incorporation of these techniques into physiotherapy protocol may offer an effective and non-invasive approach to management of TMD, particularly when tailored to individual patient needs. And these are some of the references I have used in this study. And thank you everyone for providing me with this wonderful opportunity.